Hello and welcome to our ENDO 2024 news conference on our new vitamin D clinical practice guideline. We're delighted to have you all here in Boston with us today. My name is Colleen Williams and I'm the Senior Manager of Communications here at the Endocrine Society. I'll start by introducing our guideline authors who will be speaking today. We have Dr. Marie DeMay of Harvard Medical School and Massachusetts General Hospital. She's the guideline chair. Dr. Christopher McCartney of West Virginia University, and Dr. Anastasios Pittas of Tufts Medical Center, who is the co-chair of the guideline. Over the next 30 minutes, our speakers will present the key points and recommendations in the guideline, and then we'll end with a Q&A at the end. Please note that the conference is being live streamed, and we have a lot of journalists joining us remotely today. Because we're live streaming, it's really important for all remarks to be made into the microphone to enable those who are joining virtually to be able to hear what's being said in the room. Journalists who are attending online will be able to type their questions into the chat at any point during the news conference, and we'll address those during the Q&A. So I would now like to invite our first presenter, Dr. DeMay, to speak.
Thank you. I would like to discuss a little bit of a background of vitamin D and the rationale for the guidelines. And these guidelines are to address the vitamin D requirements for disease prevention in healthy adults who have no underlying conditions that would put them at risk of impaired vitamin D absorption or vitamin D action. So where do we get vitamin D from? How does it work? And why does it matter? So when we look at the history of interest, let's say, in vitamin D, in 1974, vitamin D, we thought, played a critical role in the skeleton, in bone mineralization and prevention of rickets, as well as in intestinal calcium absorption. And basically, between 1900 and 1974, there were probably about 2,000 articles published with vitamin D in the title in PubMed. So fast forward to 2024, in addition to these two areas, there's a lot of interest in the actions of vitamin D in immune response to pathogens, in autoimmunity, in inflammation and fibrosis, in cardiovascular diseases, metabolic diseases, cognitive function, muscle function, reproductive function, aging, and numerous other areas. And at this point, there are well over 3,000 articles per year on vitamin D and its actions. When we think of how we get vitamin D, basically, we get it through the skin in response to ultraviolet radiation. However, when we look around, this is how most of us spend our days, in conference centers or buildings, wearing long sleeves, long pants, and really don't get a lot of sun exposure. Even if you were going to go outside today with an overcast sky, there would be insufficient solar radiation to get a significant amount of vitamin D produced. So most of us depend on the oral intake of vitamin D, which needs to be absorbed, and regardless of where it comes from, it's 25-hydroxylated in the liver. And we use 25-hydroxyvitamin D as a measure of vitamin D stores because it's the most stable metabolite of vitamin D. Vitamin D then traditionally goes to the kidney where it's activated to the active metabolite 1,25-dihydroxyvitamin D. However, in addition to the traditional pathway where the active form of vitamin D goes into the cell and then into the nucleus where it binds its receptor, there are non-traditional actions where the precursor hormone, 25-hydroxyvitamin D, can enter the cell and under certain stimuli be converted to the active form and then activate gene expression. The thing that's really important about this is that there are 3 orders of magnitude difference between the circulating levels of 125 and the circulating levels of 25-hydroxyvitamin D, with the levels of 25-hydroxyvitamin D being much higher. So when we think of a traditional target, the intestine is a classical target. where we know that vitamin D promotes intestinal calcium absorption, and by doing so, it prevents an increase in parathyroid hormone due to inadequate calcium absorption. So if someone is not absorbing calcium, parathyroid hormone goes up to maintain normal calcium, and it does so by taking calcium out of the bone and preventing calcium loss in the urine. So with phosphate, this vitamin D and calcium normalizes skeletal mineralization, and by maintaining normal phosphate levels, prevents rickets. So how do we evaluate vitamin D action? In the traditional target, the intestine and the bone, on calcium absorption, circulating parathyroid hormone, calcium and phosphate are surrogates or biomarkers, let's say. On the skeleton, we can do growth plate x-rays for rickets, and surrogate lab tests are also calcium, phosphate, and alkaline phosphatase. And for bone per se, biopsies can be performed for osteomalacia, but we rarely do that. So once again, we use these surrogate biomarkers, lab tests like calcium, phosphate, and alkaline phosphatase. So shifting to the non-traditional target, the immune system, there are articles that suggest that vitamin D promotes host defense against pathogens and attenuates autoimmunity. So how do we evaluate vitamin D action on non-traditional targets? So we have no biomarkers for this, and this is what makes it very difficult to assess whether someone has enough vitamin D to prevent a disease. So on host defense against pathogens, if you're looking at short-term respiratory infections, these can be short-term studies, maybe over a season of a winter, looking at the effects of vitamin D on prevention of these infections. On autoimmunity, once again, looking at the incidence of autoimmune diseases is the only way we have, because surrogates of inflammation can be seen in a number of different conditions, and most are not specific for autoimmune diseases. And the other thing that's very challenging with these studies is that they have to be long-term studies. It's not as if it happens over a period of a month or a week. These have to be for 5 years to several decades, especially if we're looking at vitamin D status in childhood, preventing autoimmunity and autoimmune conditions in adulthood. So we actually encountered many challenges in formulating these guidelines. One of the first ones, as you can imagine, is you can't really have a placebo group, because it's not as if we're giving someone an antibiotic or a pharmacological agent. We don't know how much solar exposure people get. The other thing is that many of the clinical trials that we examined allowed the control group to remain on their vitamin D supplements up to the level recommended by the Institutes of Medicine. The other thing, in terms of looking at skeletal outcomes, they really can't be dissociated from calcium intake, because one of the major effects of vitamin D on the skeleton is to promote calcium absorption and provide an environment with adequate calcium and phosphate levels to promote mineralization and prevention of rickets. So what we really need going forward is randomized clinical trials in those with different levels of vitamin D, starting with low levels to levels that we currently think are adequate, examining specific outcomes in response to different vitamin D doses and target levels. And one could imagine that target levels required for traditional outcomes may be very different than target levels required for non-traditional outcomes. The other thing I alluded to previously was that these trials really need to be based on the natural history of outcome examined. So cancer doesn't happen overnight. It doesn't go from a totally benign condition to a malignant condition in 2 years. So a lot of these diseases have long latencies, such as malignancies, osteoporosis, autoimmune diseases. And we also need randomized clinical trials in different racial and ethnic groups, also considering body composition, environmental, lifestyle, and dietary factors, and also randomized clinical trials focusing on prevention of specific diseases, because as I mentioned, the doses or the levels required for prevention of different diseases may vary substantially. Thank you.
Great, thank you so much. I'd now like to invite Dr. McCartney to speak.
Good morning. I served as the guideline methodologist for this particular guideline, and I'm just going to very briefly summarize a bit about the methodology we used. And the first comment I want to say is that over the past 5 to 7 years, the Society has devoted substantial effort and resources to improving its methodology to make our guidelines as trustworthy as we can. So starting with the guideline development panel, we convened a multidisciplinary group, and what you see here that we have subject matter experts from a number of arenas. We had adult endocrinologists, a pediatric endocrinologist, a handful of general internists, a maternal fetal medicine specialist in the field of OBGYN, a nutritionist, an epidemiologist. We had 2 guideline methodologists. I was the one taking the lead on the GRADE implementation, and GRADE is a structured approach to guideline development. And we had a methodologist from the Mayo Clinic that we partnered with for years who took a lead on the systematic evidence reviews. And we also had a patient representative on our panel to help us understand the patient perspective. We used a system called GRADE, which is a very common system for developing guidelines. It stands for Grading of Recommendation, Assessment, Development, and Evaluation. And very briefly, I'm going to tell you about the 4 steps. The first 2 are here. The GDP stands for Guideline Development Panel. Brainstorms about what are the most important clinical questions that are being asked by clinicians and patients. So after that brainstorming, the clinical questions were prioritized and then finalized. And then we selected what are the outcomes that we think are most important for decision making. After that, we handed off those questions and outcomes of interest to our Mayo Clinic team who did the systematic reviews. And as part of that evidence collation and synthesis, they helped us understand what's the certainty of evidence. In other words, when they, by looking at the clinical trials, they give us estimates of the effect of vitamin D, for example. How confident are we in those estimates? Do we think it's very close to the truth? Are we uncertain about how close it is to the truth? And so we incorporate that into our thinking as we're developing the recommendations. Then after we get those evidence synthesis from the Mayo Clinic, we go through a process called evidence decision, and that's the process of taking the evidence and converting it into a recommendation for clinical use. The panel addressed and made judgments about a number of important considerations that I'll highlight in just a minute. And then after consideration and weighing all of those things, then makes a recommendation about whether clinicians and patients should use the intervention, in this case vitamin D, or vitamin D testing, and making judgments about how strongly the panel recommends that. Do we think this is a strong recommendation, or do we think it's a conditional recommendation, which I'll talk about again in a minute. So these are the factors that we really consider as we're trying to make judgments about whether the intervention should be used or not. We often think about the health effects. What are in this case, let's take the example of a clinical question where we're asking, should this population take vitamin D or not? We ask, what are the health effects? What are the benefits of vitamin D that we see in the clinical trials? What are the undesirable effects that we may see in the clinical trials? And we want to know what are the balance of those effects. Do you get more benefit than harm? And we're also considering, as I mentioned before, the certainty of the evidence that we have, how certain we are that we actually know that balance of benefits and harms. Importantly, we also think about a number of contextual factors. How much does this intervention cost? What kind of resources are required for this particular intervention? Is it a cost-effective intervention, or do we know that? what might be the impact of this intervention on health equity? It's something that the Endocrine Society has been very interested in trying to pay close attention to this. And is this intervention something that's acceptable to important stakeholders? And is it an intervention that's feasible to implement? Taking all of these factors, the panel weighs, are the desirable effects of vitamin D, for example, do they outweigh the undesirable effects? And all of these can be desirable or undesirable effects. And we see this sort of scale here. This would help us understand, should we recommend or should we recommend against vitamin D, for example? So that leads us to our recommendations. We have a direction. Do we recommend for or against vitamin D, for example? And how strongly do we feel we can make that recommendation? If the balance of beneficial effects is very favorable, we may issue, if it's clearly favorable for vitamin D, for example, we may issue a strong recommendation. And basically that means we feel that most, if not all patients would want this, and most patients should get vitamin D, if we were to say that. Conversely, if we thought the harms outweighed the benefits for almost everyone, and we were confident in that, we may issue a strong recommendation against. These are just examples. To maybe let the cat out of the bag a little bit, we issued no strong recommendations. All of our recommendations were conditional. And what that means is maybe the balance is not completely obvious. And that different patients may have, based on their values or what they want, they may, when we offer a conditional recommendation, we feel that most would want to follow the suggestion, although a substantial minority may not want that. So in that case, when we issue conditional recommendations, it implies that the clinician still needs to understand the data, talk to patients about their values, and enter into a shared decision-making process. And with that, I'm going to turn it over to our co-chair.
Okay. All right. So before I give you the recommendations, I'd like to go over some key concepts that we need to understand, and these are important to when interpreting the recommendations. So the first point is, again, to repeat that this guideline refers to vitamin D for disease prevention in generally healthy populations who do not otherwise have indications for vitamin D treatment or testing for blood levels. So, for example, people with established osteoporosis, this guideline does not apply to them. Another point I'd like to make is that there's no single question or single answer about vitamin D. We physicians, and I'm sure you get this question a lot, what should I do about vitamin D? And I don't know what to tell you, how to answer that question. So there are many questions, and the panel could not possibly answer all possible questions. So we identified 14 questions that we thought were clinically relevant about the role of vitamin D in health and disease, and that apply to specific groups of people and specific health outcomes. Again, that's an important point. The panel placed emphasis when reviewing the evidence, placed emphasis on clinical trials versus observational studies. Observational studies, pretty much all of them have shown that people with higher levels of vitamin D are at lower risk of developing disease in the future. But observational studies suffer a little bit from confounding. And in this particular case, what that means is that people who have high vitamin D levels, they may also be younger, thinner, they may be eating better, they may exercise more, so they're just overall healthy. So therefore, there may be their overall healthy status that determines or predicts better outcomes and not the vitamin D level. And the last point is that when we made recommendations in favor of vitamin D, what we mean by that is in addition to the recommended daily allowance by the Institute of Medicine that was established more than a decade ago, and that is defined by 600 units per day for most people and 800 units for those older than 70. All right, so with that background, we can divide the recommendations into 3 general categories. The first category is where we found evidence that for groups that may benefit from more vitamin D than the RDA. So these are children to lower the risk of rickets and respiratory infections, in pregnant people to lower the risk of maternal and fetal and neonatal complications, in adults older than 75 years to lower the risk of mortality, and in adults with high-risk prediabetes to lower the risk of progressing to diabetes. Again, what we mean here is empiric dose of vitamin D above the RDA and without the need to test for a blood vitamin D level. The trials we examined, they used, as you can imagine, varied doses of vitamin D, and therefore the panel was unable to define the optimal dose of vitamin D for these populations. When we reviewed the evidence, we did not find clear evidence that people who are younger, healthy adults who are younger than 75, would benefit from taking more vitamin D than the recommended RDA, and therefore we did not make a recommendation for that. The last the last category refers to the dose of vitamin D when indicated. So we recommend daily vitamin D versus intermittent high doses of vitamin D, and the latter is defined as any dose greater than 50,000 units. And last but not least, we did not find clear evidence in favor of testing, and therefore we do not recommend routine testing for vitamin D levels in the general healthy population, and that includes those with obesity or dark complexion. And that completes the presentation, and here is a summary of the guidelines that you can also find in the publication that will be available at 11:30 or something like that right after the presentation, and happy to take any questions.
Thank you all so much. I'm going to turn it over to my colleague Jenny for the Q&A. We'll be taking questions from journalists in the room as well as online, so please remember to include your name and outlet if possible.
Hi, Miriam Tucker with Medscape. I know I've been hearing over the years people say that the majority of the population is vitamin D deficient. Is that not correct, or are you saying it doesn't matter? And what does that mean even?
You are correct that this is what we've been hearing, especially with the NHANES surveys. However, the question is whether the majority of the population actually takes the recommended daily allowance of vitamin D that's suggested by the Institute of Medicine. And the other challenge that we've had, as I've mentioned, with the randomized clinical trials, so most of the people who volunteer to participate in these trials may not represent the general population, and many of the trials had levels that most, if not all, would consider to be sufficient, presumably because they were allowed to stay or they were taking the recommended daily allowance. This is very different than the trials that happened, in the 90s, right, 1990s. So I think as the word has gotten out, people have adhered to the recommended daily allowance, and then there are some people who take more, but there's no evidence for that in the groups that Dr. Peters discussed.
Yeah, I just want to say that the answer to that question depends on how vitamin D deficiency is defined, right? And it's typically defined by a vitamin D level less than, we don't know. And that's what the our guidelines found, that there was just not enough evidence to define a specific threshold that would, to establish a specific threshold that would define deficiency or sufficiency, especially since that likely depends on the population.
Mike Menasher from Helio Endocrine today. So I have sort of a two-part question on sort of the vitamin D dose for these specific populations, because we don't, as you said in the presentation, we don't really know what the optimal dose is. So how should providers or just people in the public approach that if you're in one of those categories? And I guess the second question is, what do we need to do research-wise to sort of kind of pinpoint what the optimal dose may be for those specific populations?
I'll take the second one, which I think is pretty straightforward. Ideally, you'd want to do clinical trials in people with different levels and target different levels. And the challenge would be not only doing that, but also considering the natural history of the diseases. For instance, respiratory infections, the trials could be a year. Other things, trials may need to be decades, especially if you're looking at interventions during childhood to prevent outcomes in adulthood. I'll take the other one.
Oh, thanks. Again, the evidence could not point to a specific dose, so we cannot give you a specific dose, but for every question, we gave the range of doses that were used in the studies, and we did come up with the weighted average dose for that specific question. So the answer to your questions is in the document. It varies for each specific recommendation. In general, again, we didn't specifically study this, but in general, we think that going over the IOM recommendation of 4,000 may not be necessary, but again, we can study that in studies that target that type of question.
Just to follow up, part of the challenge was that, as Tasso mentioned, that the trials use different doses, and not only did they use different doses, some were daily, some were monthly, some were one time, and so it was really impossible to define a dose, but a dose range is provided.
Great. Do you have another question?
When you're talking about the recommended daily intake from the IOM, you're talking about dietary, correct? But how do you?
We're talking about diet plus any type of supplement you need to take to get up to that amount.
But how
So
do you? Yeah.
if you're not taking any vitamin D, then in your diet, then you need to take a pill.
How do you know if you're getting enough from your diet?
You read nutritional labels. For instance, dairy milk has vitamin D, but a lot of yogurt does not. So there's a lot of, it's work. It's work.
Great, and that's all the questions in the queue.
Great.
All right.
Great. Thank you so much to our speakers and journalists who took the time to take part in the conversation today. As a reminder, the recordings of the news conferences will be available on our website and YouTube channel following the presentation. And if you have any questions or want to set up an interview with any of our speakers, please contact us at media@endocrine.org. Thank you so much and have a great rest of your day.